Well, it's the end of a long day, and this is really a lecture of reassurance, false positive mammographic interpretations. As you'll be seeing during the course of the talk, there's a considerable amount of overlap in the appearance of benign and malignant disease in the breast. Excuse me. And in fact, our malignant yield at biopsy is unfortunately quite low. One thing we do know, though, is that with more aggressive mammographic screening, we've been able to accomplish a 30% reduction of breast cancer mortality in women over age 50. And that's when screening has been done combined with repeated physical examinations. This data has come from European studies as well as a large health insurance study in New York. I want to emphasize that breast self-examination remains, though, the most important method for the detection of breast cancer. Mammography, though, has the potential to demonstrate early, non-palpable, resectable breast cancer, and the early diagnosis of breast cancer, of course, increases the chances of total cure. One thing we do know, statistics tell us that the incidence of breast cancer increases with age, and because of these statistics, we follow American Cancer Society guidelines and obtain more frequent mammograms in the greater than age 50 age group, yearly after age 50, every other year between ages 40 and 50, with a baseline study being obtained around age 35. If there are strong risk factors of a strong family history of breast cancer, then we'll change those recommendations and obtain yearly mammograms from about late 30s on. We rely on principal signs, radiographic signs, to diagnose malignancy, and they're great when we find them. Unfortunately, we rarely find all of these features in a given case, and it's usually a fairly advanced malignancy that will demonstrate all of these signs. One basic finding would be a mass density, a focal mass density within the breast, which we do see here. This is a biopsy specimen on your right. Calcifications, irregular, varying in appearance, are sometimes seen. Retraction and distortion of the breast architecture is an ancillary finding, more worrisome if we see a mass lesion with distortion of breast architecture. And probably the softest finding would be skin thickening or edema overlying a breast mass. But I'm going to show you a couple of cases that illustrate the difficulty and underscore the high false positive rate in interpreting mammograms. This is a patient who had no known risk factors, had fatty replacement of most of the breasts. I don't know the patient's age. I would guess probably around age 50. And we see in the left breast a focal mass density with architectural distortion surrounding the mass. This is the craniocaudad projection, and I can just tell you that on the oblique views we saw the same finding. And in the right breast, a similar spiculated focal mass density. As you can see in the left breast, this abnormality yielded mammary dysplasia, while in the right breast, the abnormality yielded intraductal carcinoma. We will often use, and I'm sure you all do in practice, magnification views, this being a magnification 0 mammogram, to provide better contrast enhancement of the lesion and better analyze its borders. And this is the biopsy specimen of the other lesion. This was the focal nonspecific mass density removed from the left breast. Another case illustrating the same point. Again, craniocaudad views. In the right breast, we see an ill-defined mass density, some evidence for distortion of breast architecture that yielded intraductal carcinoma. This lesion, though, was equally focal and solid on ultrasound. On resection, revealed fibroadenoma. Now, this issue of false positive biopsies has been reviewed by most large centers This was a report that was out in 1984 from the Mass General, where 500 abnormal mammograms were reviewed that had gone on to biopsy. In this series, 117 yielded malignancy on biopsy, which was a yield of 23.4%. In fact, the large series at all centers have revealed a yield of 20 to 25% of malignant yield at biopsy based on mammographic findings. In this series, biopsy was prompted by calcifications, abnormal, indeterminate calcifications in about 40% of cases, and occult masses, non-palpable masses, in nearly 60% of cases. And as you can see, the masses either had poorly defined borders, were lobulated, or were associated with architectural distortion. Note that only 9% had the latter feature. Another series, more recent, came from Jefferson Hospital in Philadelphia, where I believe it was close to 200 cases. I'm not sure of the exact number in this series. It was a large series where occult breast lesions were analyzed more specifically and broken down as to the malignant yield depending on the finding. And this was an interesting study because it pointed out that when dealing with a solid mass alone on a mammogram, one encountered a malignant yield of about 10%. But when dealing with indeterminate calcifications, the yield was much higher and was more in the 30 to 40% range. So it's only when all of these abnormalities are averaged that we will speak of a 20 to 25% yield of malignancy on biopsy. Here we have a lesion that is a focal, obvious focal mass lesion, fairly well circumscribed borders along part of the mass, but indistinct borders where the mass is either obscured by overlying breast parenchyma or just the breast density itself. When dealing with a solid mass without calcifications and we are deciding what to do with it, the very first step to do is ultrasound. Actually, the very first step is to have an old mammogram to compare to. More often than not, though, we don't have that in a screening setting. And this lesion, when subjected to ultrasound, revealed classic cystic characteristics: no internal echoes, side wall shadowing, posterior wall enhancement, and we were confident assigning the diagnosis of benign cyst. A less distinctly seen mass lesion, more obscured by overlying breast parenchyma when looked at sonographically, was solid. Here we see none of the posterior wall enhancement, none of the side wall shadowing. This was a solid mass, went to biopsy, and yielded intraductal carcinoma. Here we see a mass in the retroareolar region of the breast, fairly well circumscribed borders. It looked very much like both the carcinoma and the cyst that we demonstrated before. This lesion was symptomatic and was aspirated. Air was then injected into the cyst, and here we see very smooth walls. Another way of demonstrating a cyst, perhaps a little bit older a method than using ultrasound. Here we have another fairly well circumscribed mass. Looks like one large mass, but with ultrasound we see in fact there were two large cysts, maybe even a third, all within this amount of breast density. In analyzing these masses sonographically, you have to be very careful in setting your gain settings with the ultrasound unit, that you don't create internal echoes and misinterpret a simple cyst for a complicated cyst. Skin lesions sometimes can be a problem as far as interpretation goes. Usually, though, you can correlate your exam with a physical exam, or your technologist can. And in this case, it was a case of known neurofibromatosis with multiple skin lesions. Notice also that most of these lesions have a halo sign surrounding them. The halo sign is an older sign that we don't rely on too much in mammographic practice anymore. We used to believe that the halo sign conferred benign diagnosis in all cases. In actual fact, though, another Boston group has looked at this and has found that the halo sign has been associated with malignant lesions in a small percentage of cases, but a reportable number of cases over about a 5-year period. So beware of the halo sign, and certainly proceed to ultrasound when analyzing a breast mass, and if a lesion is solid, it should be treated aggressively. Another solid mass, retroareolar, somewhat more lobulated appearance that yielded colloid carcinoma. These are the lesions that we don't want to write off as benign cysts in mammographic interpretation. And this one, perhaps could even be argued, looks even more benign. Certainly there are sharp borders along the posterior aspect of this lesion. That was another slow-growing carcinoma, a medullary carcinoma. This is a case of a fibroadenoma, very well circumscribed along a portion of its borders, but was solid on ultrasound and therefore went to biopsy, yielding fibroadenoma. Notice that while we are getting away from zeromammography, it is nice to have it as a backup unit to analyze borders of a mass. It has great usefulness in analyzing borders of masses as well as calcifications, if you have the equipment. I'm not recommending, though, that everyone go out and invest in zeromammography. We find poorly circumscribed lesions more worrisome in interpretation as we move into the less well-defined masses. These include abscesses, hematomas, focal mastitis, which really is a subgroup of abscess, papillomatosis, rarely metastatic lesions of the breast due to lymphoma, lung cancer, melanoma. This is a case of a retroareolar mastitis, an infectious mastitis. Here we see induration of the retroareolar region, nipple retraction, common features commonly seen during nursing. The important point to take away is that mastitis can be broken down into the infectious entities, most commonly staph or streptococcal infection, rarely tuberculosis or syphilis, and even more rarely plasma cell mastitis. This is a case of plasma cell mastitis, indistinct mass-like density in the retroareolar region of this breast when compared to the other. This is a non-infectious entity, also called mammary duct ectasia or comedomastitis, depending on your pathologist. And these different terms probably reflect different stages in the disease process. Duct dilatation, occlusion of ducts by white cells, periductal inflammation. The worrisome features, though, more often are the symptoms that accompany plasma cell mastitis, as they can mimic an inflammatory carcinoma. Symptoms of pain and tenderness, induration of the breast, fixation and retraction of skin overlying the breast, and even more worrisome, axillary nodal enlargement. And as I mentioned, this being a non-infectious entity, there usually is not a history of nursing or breaking of the skin to explain the abnormality. So these lesions commonly will go to biopsy to make the diagnosis. This is another ill-defined lesion. If we look at the image first on the left, this was a patient who had undergone a biopsy procedure and had this ill-defined mass density persisting after the procedure with another mass density, ill-defined, nondescript, certainly not a specific appearing mass, just deep to it. And in a short time interval afterwards, approximately 3 months, we see that the hematoma that was caused by the biopsy has now resolved completely, and we're left with this structure that is now smaller in size and has the more characteristic appearance of an intramammary lymph node, the V-shaped or mass density with a little divot out of it is an Ant Mini, of course, as we all know, for an intramammary lymph node. It's great when you have that appearance, but not all intramammary lymph nodes will be so distinct. And of course, they're solid on ultrasound. The spiculated lesions that can be confused with carcinoma include post-biopsy scarring, fat necrosis, mammary dysplasia. Plasma cell mastitis also fits into this group. Rarely sarcoidosis or tuberculosis. This is a very ill-defined mass lesion deep within the right breast. We did not biopsy this mass only because we had old mammograms that went back quite a number of years documenting no interval change in this appearance. And this probably represents just focal mammary dysplasia. In my experience, I find focal mammary dysplasia the hardest of all the entities to analyze. It's the most common cause of a focal mass lesion in the breast in all age groups. And it usually is usually a solid lesion on ultrasound. There is usually not a true cystic component to go with a mass like this. But this lesion was unchanged for over a 6-year period. So we ascribe the diagnosis of focal mammary dysplasia to the mass. Mammary dysplasia, as you know, results from exaggeration of the menstrual cycle, the hormonal changes in the menstrual cycle, and depending on the age group can be divided into 3 histologic types. Also, depending on your pathologist, different terms may be used instead of mammary dysplasia. Fat necrosis is easily recognized when there is a lipid center within the distorted breast parenchyma. The spiculated borders of fat necrosis, though, can sometimes be difficult to analyze. We sometimes think that all cases have a history of trauma associated with them. In fact, only about 1/2 of cases will have a history of prior biopsy or surgery to explain fat necrosis. As you can see, the symptoms on presentation without that history can be worrisome. Increased consistency, suggesting a mass within the breast. So fat necrosis without a lipid center commonly will be biopsied to exclude malignancy. I'm going to move quickly into calcifications. I think that Ed might be touching on this subject a bit in his talk. Calcifications, as I mentioned earlier, will have a higher yield of malignancy on biopsy, and so we set our channel even a little more aggressively when analyzing calcifications. Benign entities that can be confused with malignancy include skin calcifications. Tattoos as well can have some pigment within them. Usually, though, we can disprove calcifications within the skin by getting tangential views. Early arterial calcifications, milk of calcium within tiny breast cysts, papillomatosis, and sometimes post-surgical changes. We rely on basic characteristics of benign versus malignant calcifications. Benign calcifications being more rounded and uniform, usually scattered throughout the breast, and malignant calcifications usually being clustered, varying in size and density, and more irregular in form. And a reference in '86 is an article by Ed in which it's a very good stepwise method of analyzing breast calcifications. Arterial calcifications are easy to analyze when they truly form an arterial structure, but sometimes you just have 1 or 2 grouped calcifications within a breast, and that will lead usually to biopsy. Milk of calcium is an interesting entity because it's nice when you see a great case of it. On lateral views, milk of calcium within cysts will layer as linear densities or crescentic densities, and when viewed in craniocaudate projection will appear as pooled calcium within the center of tiny cysts. And calcifications are very hard to project for a large slide talk. In fact, on a little bit of faith, I hope you can see that there are some layering, more linear appearing calcifications on the lateral view of this breast, and this is 0 mammography. And I don't know whether you believe me, but that's the pooled calcium within the tiny cysts. Milk of calcium is pretty easy to diagnose when you have a classic case of it diffusely involving the breast, But Mark Homer, another Boston radiologist, has described milk of calcium occurring as solitary focal disease. And in that instance, it may be harder to ascribe a truly benign entity, benign diagnosis to milk of calcium. And I forget how many cases this was, but it was a good number. Papillomatosis, a subgroup of mammary dysplasia, can sometimes present as focal calcifications. They're usually more loosely arranged than a malignant cluster, and they're usually larger and more uniform in density. How can we raise our yield, our malignant yield, and how can we improve our accuracy? Well, a number of authors have pointed to improving our technical factors, using state-of-the-art equipment, state-of-the-art screen film systems, having a lot of technical factors controlled by your technologists as to the amount of compression that's obtained on an exam, the number of projections, the patient factors themselves of how much fat and fibroglandular tissue one is dealing with, and the morphology of a given carcinoma will affect the accuracy. And your being in active mammographic practice will help. Observer experience and knowledge certainly helps for the judgment calls, the subjective evaluation of a given diagnostic dilemma. This is a case this is an overt case of patient factors. This is a patient who had both silicone injections, all of these nodular densities throughout both breasts, as well as breast implants, both of which severely compromise our ability to analyze the breast parenchyma. A slightly more unusual case of silicone injections, these large mass densities deep within the breasts that had been stable over a long period of time in a patient with known silicone injections. Here, evidently, the silicone was just focally deposited as opposed to in generally one area as opposed to the other case. The dense breast worries all of us, and this is a dramatic case of a film screen image. On faith, you'd have to believe that that was a little bit of breast distortion due to intraductal carcinoma, better seen with zero mammography. And here you see a spiculated density that on biopsy yielded intraductal carcinoma. And we have found this actually, you see our false negative rate is largely ascribed to the dense breast. Let's see, the better analysis that you can provide to a mass or a set of calcification prior to biopsy will help you in canceling some of your biopsies. Meyer, again from MGH, studied 53 cases in which nearly 10% were canceled. 10% of biopsy procedures were canceled on more close analysis of the mammographic abnormality. And the reasons for canceling the studies were that no mass was present in some of these cases. The mass was aspirated, proved to be a cyst, not well seen with ultrasound. Skin calcifications. I was rather surprised that of these studies canceled, only 2 of them were canceled because old films had become available at a later date. We, in fact, will find this more commonly, usually not at the time of a biopsy, but we very often will have to hold our diagnosis or our interpretation of a study as we await old films. There has been debate in the literature as to an aggressive approach advocated by Moskowitz to biopsy versus a more hold-back approach, long-term follow-up type approach by Ferris Hall. Most mammographers lean, I think, towards Moskowitz's suggestions of being aggressive in pursuing breast biopsies, and that the liability and tragedy of misdiagnosis is just too great to merely follow most breast lesions. So I'll conclude my talk and just underscore the considerable overlap that we see in the mammographic appearance of benign and malignant disease. We are wise to be aware of strengths and limitations of the state-of-the-art, if you will, of mammography in distinguishing between benign and malignant disease, And it's very important that you communicate this to your referring clinical staff. But despite these limitations, mammography remains the most effective imaging modality available and certainly supersedes any attempts with transillumination or ultrasound to be the screening methods of choice. And if you will, I don't know that it's quite acceptable, but a 20% malignant yield at biopsy concurs with the experience at most large medical centers, and we can improve that or get close to this number by addressing both technical and personal factors in obtaining the best mammogram that we can at the time that the patient comes to see us. And I'll close on that note, and I don't think we'll take questions probably until the last talk.